growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of the Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here. Welcome to the Lionhearted Dentist. We're into the third week of March of 2021. And this week I'm going to have a little different take. I think you'll like this on what I'm going to present to you. It's going to be pretty much clinical and right to the point. And I have to tell you that, listen, a lot of different people listen to me. And obviously I don't know what all of your interests are. But I do think from time to time, most general dentists are in a situation where either they unexpectedly have to remove a tooth or they're not sure if they should remove a tooth. And I don't think you should take the posture that you never take teeth out, particularly if you want to appeal to the masses. Let me just expound on that point. Why would that be? You might be thinking. I am 100% convinced that your patients would rather you, by the way, do all the procedures than sending them out all over town. Now, I know that they don't know your level of competency. I get that. And whether you're graded endo or ortho or taking teeth out. I get it. But I am sure that by establishing a personal relationship with your patients through the vehicle of a relationship-based practice that you hear me speak upon so often, that they would rather you do it. Listen, to make this clear, I don't provide services for wisdom teeth. Of course I know how to take wisdom teeth out. And I do it in the right situation. I have to work on a second molar, and the impacted wisdom is causing decay on the distal of that second molar. There's just a multitude of times I will do it, but routinely I don't. And there's a myriad of reasons. I could go in for everything I say to you. For one thing, I don't really send my oral surgeons a whole lot of other referrals, and I don't want them to hate me. So, and they're very good at it. And it's not that lucrative. And you're trolling in an area of anatomy that can be have multiple complications. I mean, let's just be honest. 17 and 32 of all the teeth that you take out, of all the areas that you work in, 17 and 32 simply have a host of neighboring anatomy that invites post-operative complications. So when I say to you, your patients would rather you provide the service, no. Do they want you taking out a wisdom tooth for an hour plus? No. But what if I could teach you to take almost any tooth out in 15 minutes? And I'm talking about broken to the gingival margin, a molar, history of root canal, and a large individual who has elongated roots. Does it get any harder than that? Or a cuspid, either one. And I can. And tonight is going to be the beginning of such guidance for you. And by the way, listen up. You can write to Beth or myself, and we can refer you to YouTube videos of what I'm going to be speaking about. Okay? So, I know some of you tune in every week for positive karma. I hope you do anyway. And I'm going to give you a little bit of that right now. And I'm not even sure how quickly I can get in one video, in one podcast, to the literal instruction of what I want you to do, but I am going to simplify it for you. I am not going to make this complicated because it's not. Okay? So let me get right to the point. First of all, thank you to Ireland and Germany. You're downloading me to death. And to all the others that have been listening. You know, I got to be honest. This podcast has made me happier lately because it actually seems like it's growing. And I like that. That's why I'm doing this. Yeah, it grew before, but it's growing faster. And so thank you. So let me begin by first telling you the karma stuff, the management of your empire stuff. And that would be the key operative guidance for this week is be vigilant. You know, I notice myself being vigilant all the time. You know, noticing when I heard somebody say today in my office, I'm not kidding, and this should make you feel good because you probably think that we always have it all going on great. I like to think that. And I judge that by the feedback I get from patients. You can tell if you care. And I heard one of my staff members in reception today tell a person that called who wanted to speak to the new patient coordinator / financial coordinator / office manager, Michelle. And I heard her say, yeah, she's a busy woman. Now, to be fair, this is not a permanent employee by me. She was borrowed from the second office that I own because somebody's out this week. And she has a lot of good merits and qualities, this person I'm referring to. And she doesn't really know my ways. That's not the point. The point is that I'm at my desk and my ears are always open. If I hear a phone call and I don't even know what the person's obviously saying on the other end of the phone, I will often ask, based on what I'm hearing, could I ask you what that was in reference to? Some of you may think that's meddling or over the top. No, it's not. It's me, man. It's my name. It's my brand. And I am fortunate to have team members represent me, as do you. But it's got to be my brand, and not everybody knows. I care about everything. That's what I mean by being vigilant. And I never stop caring, and I would hope you would be that way. Oh, by the way, in the event that any of you are actually watching this and not just listening, if I look a little different, it's because I stopped my podcast at 9 minutes and got a haircut because I didn't have a choice. Because this is at night after work when I get these kind of things done. Okay, just in case you're wondering. All right, so back to the podcast. I've talked about a management principle of being vigilant. I told you, and it's a great payoff, by the way. Being vigilant to whatever business endeavor we're involved in would obviously be a good attribute, a good cornerstone of managing this organization that you work so hard to put together. And I'm just saying, after all these years, I still do it. And I react to it. And I don't mean by being a hostile dictator. Look, I've told you many times, I have 20 employees. And I don't have a handle as much on the 6 or so that are at my other office. I rely on things I hear, or sometimes I'll call the office to see how the phones are being answered and whatnot. But I think you get the point. So I told you earlier today that I wanted to focus on specific clinical strategies to broaden your skills, to broaden the skills for the purposes and satisfaction of your patients and yourself. And I know a lot of you listening maybe have never taken a tooth out, or it's stressful for you. I think that's more the case. And it's stressful Because in most situations that I'm familiar with, you are taught to use forceps. I'm talking back in dental school. And that is an incorrect way to take a tooth out atraumatically. So the first step, if let's say this is going to happen in a month, based on some principles I'm about to share with you. The first step, for real, of a successful removal of one tooth or several is managing that patient. So I would say to you in general, a safe rule of thumb is to see most of those type of patients early in the day. Number two, if you go back to your original information intake of this patient, I think you should stick to ASA 1 and ASA 2 patients. I absolutely think you should refer anything above that out. I'm just giving you tips just roll off the top of my head before I get to exactly clinically what you should be doing. That'll make your life less stressful. If you listen to me in this short remaining time that we have, even just through audio, or if you write to me and need a follow-up, whether it be a direction to a video I've done or instrumentation I'm about to share with you, there's no doubt that you can use this as a takeaway and exercise such skills. A couple of things. So see them early. If it was me, and whatever you're allowed to under the permit that you may have, in most states in the United States, I'm pretty certain you can give one drug. If you combine, that one drug might be nitrous oxide, by the way. Or maybe not nitrous oxide, but a Valium. Or in my case, the benzodiazepine that we always use is triazolam. We use 0.25 milligrams. There's no doubt about that if a patient will consent to that, you'll have a much better, and with that goes they can't drive to the office or drive away from the office if you're going to give them a benzodiazepine. Okay. So I'm going to repeat it. Most states in the United States without a permit, just as being a licensed dentist, will allow you to use one drug, be it a benzodiazepine or nitrous oxide. When you combine the two, and by the way, that's not my sedation protocol. You've heard me say it on this podcast many, many, many times. Mine is Atarax, Benadryl, Triazolam, and nitrous oxide. Sometimes we don't use the nitrous. Today in the office, on a couple of my cases, the patient was pretty zonked on the other three parts of my prescription, and we had the nitrous on just oxygen. Okay? So, again, I would not work on frail patients. I don't even do that. And by the way, we don't sedate children. I don't sedate and use my cocktail on anybody under 18. And you may think that's over the top and maybe I'm too conservative. Knock on wood, we haven't had a serious untoward reaction to anything I've done clinically in the office or at home, ever. I don't think that's an accident. I think that is a product of the approach that I'm sharing with you. Not ASA 3s, not sedating children. You may ask, if you haven't already, why wouldn't somebody like Rasner does so much surgery, which I do? Why don't I do IV sedation? And we all have our own philosophies. And you're listening to my podcast, so it's my philosophy, which is, I think there's a lot on your plate just providing great clinical care. I think one of the two gets compromised, it's my opinion, when you, the dentist, IV sedate the patient, and provide the clinical care. Let me tell you something. A lot of you listening, or maybe you'll send me mail that disagrees with me, and it's your option how you want to practice. I can tell you for a fact that I know a lot of people in the OR, in multiple hospitals. And a lot of times, this is my caveat to you tonight about providing IV sedation. I'm not talking about if you bring in a nurse anesthetist or a dentist anesthetist. I'm not talking about that, because I do that frequently. I'm talking about you, and a lot of my close friends do what I'm telling you probably not to do. A lot of times in the OR, where they're better equipped to handle emergencies than you are in a dental office, where they can intubate. Can you intubate at the stroke of a second when you need to? Sometimes the patient has underlying conditions that the patient didn't even either not report or know about. And they will have a crash in the OR. And let me tell you something, it's panicky. Sometimes it's very difficult to intubate a patient. For the life of me, I don't need any more complications than I have. And my hat's off to those of you that have taken and received advanced life support training and provide IV. But if I was to advise one of my colleagues, which is what these podcasts are, you can go a long way with a broad spectrum of procedures with the oral sedation cocktail that you hear me talk about. That's all I'm going to say at this point, because I got sidetracked. The next thing that we need to talk about is the painless injection. Because maybe your patient is not sedated. And maybe this is on the spot, but they're uptight because, they've come to you, they broke off a tooth that morning, and maybe this is the morning that you're going to listen to my technique. So the painless injection technique really is a painless injection technique. And even if you don't utilize it for the reasons of trying to take a tooth out, you can use it for everything else. Maybe most of you know this, maybe you don't. It goes like this. The first thing you do is you provide a very powerful, or the most powerful topical agent that exists. Remember, I'm trying to get you to attract fearful patients. Some of those patients, fear stems from the injection. So that's why we're talking about this. I use a pharmacy in the United States that makes a topical that blows away any other topical I've ever purchased. But I'm going to give you the ingredients so you can have a pharmacy mix it up if you're listening to me abroad or in Russia or South America. And it's 100 milligrams of lidocaine, 100 milligrams of prilocaine, 40 milligrams of tetracaine per milliliter. That's, if you want to go to your pharmacy, that's what it is. I can send this to you if you're listening right now. Just tell me to send the topical chemical makeup of what we use in my office. So this may seem like a lot of work to you, but it is how I build a big part of my practice. It is protocol in my office always to approach any type of injection the way I'm describing right now. So it starts with a topical. The next part of the topical, the next step in that is 4% Citinest. And the reason you use that is because it has a neutral pH that does not sting. And it's in its own anesthetic syringe. In other words, I don't use the needle twice. So for local infiltrations on any maxillary shot or palatal shot, I take it back, on any buccal maxillary shot and in the mandible, including blocks, I first give the topical and then 4% Citinest Followed by, now when I say I give it, if it's infiltrated, I'm giving probably I'm giving just a couple drops in each area, because I'm going to follow that with a different anesthetic syringe that has my anesthetic of choice, which is articaine or septicaine, as many of you know it. The only time that changes is if I'm doing a mandibular block. I will first use a 30 gauge needle with citinest in it, followed by lidocaine in a 27 gauge needle. By the way, I'm sorry, this is all written down. All you got to do is write to me. But this protocol is worth it. So in my office, if you walked into an operatory right before we begin to work, there's 2 syringes out. Always. And of course, there's a topical that I already alluded to. So, you want to, how bad do you want it? You always hear me say that on these podcasts. Well, I wanted it bad enough that back in the day, I remember when I made the transition from just going in with lidocaine. Try if somebody try it on you. Tell me if this technique I'm describing for you is not different, not significantly different in terms of what you feel when you're being anesthetized. Okay. So back to our tooth. Let me give you first a single-rooted tooth. Let's start, and we'll end tonight with a single-rooted tooth, and we'll pick up next week with a molar. This principles are going to be very much the same. Now let's pick the single tooth in the aesthetic zone that's adjacent to a whole set of crown and bridge you've done that you don't want to mess up. So this tooth is broken to the gingival margin. It is non-restorable. It is an endo tooth or not an endo tooth. Okay? Doesn't matter. What you're going to do is create something called a trough. A trough. That is a little trench on the mesial and distal of that tooth adjacent to the root. And you're going to use a very specific burr. Rasner makes this burr. They don't pay me to tell you that, not a cent. And the numbers, or you can write to me, just say, could you send me the armamentarium you use? And I'll send it to you. But the burr, in case you are at a place you can write it down, is 859.38.010. And you need at least 10 of them to start. Because in certain bone, they seem to burn up quick or go bald. Okay? And when you see this diamond, you're going to get what I'm trying to tell you, because I don't know of another diamond, or I would recommend it, that you can use that is so thin that you can just hug the root, create this little slot that I call a trough. I'll explain why in a second, on the mesial and distal. Now, those of you that are not familiar with this, a few more rules. Never take the drill through the buccal, the burr, or the palate. It has to always be interproximal, because interproximal bone will always grow back. And naturally, we want to use the thinnest burr we can use so that we don't hit adjacent bone. And I will tell you, it works in the tightest corners. So what do you do now? So here will be the fear of most of you, or the mistake. You won't go low enough. You won't. I am telling you, the burr, from the tip of the burr to the part that's in the drill, is 21 millimeters. The cutting edge is less than 21. But if you took the drill as far as you could take it down, it's 21 millimeters. And you want to do that. There's no structures down there in the bone by the root that you're going to hit that you're going to hurt something. And so take your time, create a trough, and a proper fresh burr, as you've heard the phrase before, it does cut like butter. And you're going back buccal and palatally, stopping short of either the buccal or the palatal wall. That is a slot that you're creating to put an elevator in. All you have elevators in your office from somewhere. I will tell you, luxators, and there's only 4 different types of luxators that I use, is all you need. And you put the one that will fit in the slot that you just created. And then you create torque, meaning you turn the handle so that you put pressure away from the buccal root toward the palatal or toward the lingual, whatever arch you're on. Here's the secret that most dentists either don't know or they don't employ. It's not a herky-jerky motion where you keep jerking the elevator against a tooth. It's one movement away from the buccal, and you hold. This is, if you remember this, you will send me a thank you card or a nice email. You turn it and you hold for 10 seconds. You turn the instrument and you'll feel resistance. Just hold till you feel resistance for 10 seconds. And then you go to the distal side, again turning away from the buccal, because you're trying to preserve the buccal wall, which you're going to do, even if it's thin. And what will happen is this tooth, when you go back and forth, will suddenly get loose and literally pop up a little bit. And you'll be able to take it out with a hemostat or a forceps, just lifting it up. You won't be putting any pressure on the tooth. That's an atraumatic extraction, my friends. Now, I'm going to repeat real quick because I don't want you to... It's not complicated. By the way, if this tooth wasn't broken at the gingival margin, the very first step for me is to decoronate the tooth, meaning I would go horizontally and cut the tooth off to the gingival margin so that I could reach greater depth down the roots, that if the clinical crown was in place, I can't go down as deep because the incisal edge of the tooth is stopping me. Make sense? Remember, I have this on video for you. You can refer to it. Why would you not want to at least take out teeth in the aesthetic zone if you had a masterful way? You have to try something at some point, correct? Or what would you do your whole life? We try different things. I'm not asking you yet in this phase of this subject I'm sharing with you. We'll go to molars at the next podcast, of which we're going to, and it's tempting for you, I know. Oh my God, I'm putting you in a position where you can't use a forceps. You're damn right you're not using a forceps because you'll bust out the buccal bone. Okay? So, and I'll talk about easy teeth as we go on. And do you have to do this on periodontally involved teeth? Of course not. I started out by telling you I want to give you a challenging tooth. So if the tooth wasn't broken, I would take off the crown. First of all, you can see much better. Okay? You can visualize the outline of the root because it's right in front of you. And then you take the burr that I referred to, and you begin to go back and forth from the just short of the buccal to the lingual or the palate as you sink the burr down, hugging the root. It doesn't matter if you take a little of the tooth away or the root away, of course. You're creating a space that you're going to put an instrument in, and then you're going to hold that instrument, not jerk it back and forth, but hold it for 10 seconds. Then you go to the distal. Then you go back to the buccal, and that tooth's going to magically lift up for you. It's amazing. It is a great, great technique that I have used for more years than I can count. But we also have to talk about, well, what do we put in the socket? And this was an experiment tonight. You know that I've touched on clinical subjects from time to time with you, and I seem to get a great response when I do so. So I'm trying this out. If this doesn't appeal to you, you won't hurt my feelings. But I don't always want to talk just about management. I know I've said this before on my podcast, that I always used to say in my lectures that clinical excellence and taking a tooth out atraumatically is part of being clinically excellent. You don't have to be an oral surgeon or a periodontist to do that. You absolutely don't have to be. You want to avoid sinus lifts and ramus grafts, bone augmentation. I get it. But why shouldn't you incorporate into your scope of services atraumatically removing teeth and starting with single-rooted teeth? So that's my tips for this week. Remember how to give the injection. I covered that. I talked about the beginning of taking teeth out with a single root and managing the patient. Send in any questions you have. I hope this helped. I'm trying all angles with you guys. I'm having a great year. I hope you are too. I'm getting a lot of good emails. Somebody just emailed me and told me they got their level 2, whatever they called it, sedation permit. And, that allows them to give exactly the same cocktail of my oral sedation that you've heard me describe. So thanks for hanging out through the whole podcast, having me get a haircut in the middle of it. And I'll see y'all next week on the Lionhearted Dentist. See you then. Thanks.